All right, our next speaker is another figure who, through his career, has also part responsibility for the improvement in outcomes of both autologous and allogeneic stem cell transplant. And that person is Dr. Mehdi Hamadani. Dr. Mehdi Hamadani is professor of medicine at the Medical College of Wisconsin. He serves as the chief of malignant hematology and is the associate director of clinical research in the Medical College of Wisconsin Cancer Center. He graduated from King Edward Medical College with honors, and he then completed his medicine residency in Oklahoma, his fellowship in hematology and oncology at the Ohio State University. He's been a very, very active person in the Center for International Blood Marrow Transplant Research under the mentorship of Mary Horowitz and others, and is a very dynamic contributor to the field. We had him here a couple of years ago, and he's going to talk to us today about autologous stem cell transplant with a focus on non-Hodgkin's lymphoma and what the current role is, particularly in the context of available CAR T-cell therapies. So with that, let's welcome Dr. Hamadani.
So thank you, Joel, for the very nice introduction. You're very kind. Thank you for inviting me back to Kansas City. Whenever I come to Kansas City, and this is my third visit, I'm like a kid in a candy store because I absolutely love Kansas City barbecue. So I landed here yesterday, sort of basically went straight to Jack Stacked. I had my lamb ribs, I had my burnt ends. This visit is a success. So today we will talk about something relatively out-fashioned now for some people. We'll talk about how transplant cell therapy and other immunotherapies are interplaying with each other in patients with lymphomas. These are my conflicts. So I'm going to kickstart the case with a patient of mine that I saw not too long ago. He's a 28-year-old gentleman from Green Bay, Wisconsin, with MYC-rearranged germinal center large B-cell lymphoma, who achieved a CR with frontline therapies with R-CHOP. Yes, Green Bay is where the second best football team plays. Of course, I'm in Kansas City, so Kansas City Chiefs are obviously the best team, and I'm a big Patrick Mahomes fan, so I have no reservations in saying that. So 9 months after finishing his frontline therapy, this patient relapses. It is biopsy proven. My partner in Green Bay calls me. He said, hey, Mehdi, can you see this patient? I've already given the patient a cycle of salvage treatment with polar ice. So by the time I'm able to get the patient in my clinic, I knew the patient would have had 2 cycles of polar ice. So I arranged a PET scan the day I saw the patient, and this is the PET scan of the patient. So remember, this is an aggressive lymphoma patient that is relapsing early, but by the time he comes and sees me in my clinic, the patient is in a very clear PET negative remission. So how should we manage this case? Should this patient get CAR T-cell therapy no matter what? Should we give this patient consolidation with bispecifics, or should we still consider the old-fashioned autologous transplant? So if there are any fellows in the audience, your answer is CAR T-cell therapy. Forget about what I'm saying in this talk. In board exams, questions are black and white. Real life is not black and white, right? So if you see this question in board exam, your answer is CAR T-cell therapy. Bispecifics is an interesting thought. I'll come back to that. But most of my colleagues in the field will say considering autologous transplant for such patients in 2025 is heresy. This is the wrong answer. And I'll probably make an argument that maybe not so much. So why the field has shifted to CAR T-cell therapy is because we have at least 3 randomized studies that focused on aggressive lymphoma patients that relapsed early and randomized those patients to what was standard of care back then. Salvage chemoimmunotherapy followed by transplant if you responded, or taking the patients directly to CAR T-cell therapy without worrying about whether they have responded to second-line therapies or not. But in the case that I've shown you, I will make an argument that the data from these trials, while practice-changing, while very important, is completely irrelevant, right? Because in these trials, the decision about what to consolidate your patient was done before chemosensitivity was established. Right now, we are dealing with a patient that has already shown beautiful evidence of chemosensitive disease, right? Now, back in the day, these are more than 20-year-old data from Parma trial. And remember, among us, those who practice transplant know very well that high-dose therapy in autologous stem cell transplant is not a treatment of relapse, right? Autologous transplant is merely a consolidation treatment for patients who have already responded to second-line treatments. So we have essentially selected out for patients who biologically have disease that is amenable to chemotherapy or chemoimmunotherapy. And in this setting, for over a couple of decades now, we know that transplant not only had a progression-free survival benefit, it had a very clear overall survival benefit. So while ZUMA-7 and the lysocell studies are clearly practice-changing studies, right? They don't necessarily answer every single scenario that we deal with. So as the results of these studies were getting published in very high-impact journals, we were already anticipating that these studies are not going to tell us how to handle a patient that has, by the time they hit the door in transplant and cell therapy centers, what are you going to do with a patient that shows up on your doorstep already in a complete remission, right? Are we going to do CAR T-cell therapy on those patients no matter what? Or on a case-by-case in young enough, fit enough patients, you would still think about high-dose therapy and autologous stem cell transplant. So in a recent study, we looked at patients who are in complete remission who were consolidated with either CAR T-cell therapy or autologous stem cell transplant, relatively similar age groups in these patients, similar proportion of patients with high-grade B-cell lymphomas with MYC gene rearrangement, relatively similar population of patients with primary refractory disease. What was common in these patients were they were in complete remission before they got CAR T-cell therapy or autologous stem cell transplant. Now keep in mind, these data are not prospective randomized data. These are data derived retrospectively from a prospectively maintained registry in my institution at CIBMTR. So this study was led by Maziar Shadman and Fred Hutch, and essentially what we see in this study is this theme about chemosensitivity. So among patients with chemosensitive disease, consolidation with autologous stem cell transplant is very relevant, right? These patients achieve very durable disease control, which, if not better, is at least comparable to the signal you see with CAR T-cell therapies. If we look at their survival characteristics, again, the survival at least favors autologous stem cell transplant in patients with demonstrated proven chemosensitive disease. Now, there's even a more provocative scenario that we addressed even before we did study was, let's say somebody shows up in your clinic and they're just in a partial remission. They have not achieved a complete response. They are headed in the right direction, but the PET scan is still positive. So for those patients who are in partial remission, then there is again a bias in the field. The bias in the field is you must never do an autologous stem cell transplant in somebody who has not achieved a complete remission. And my argument is always, if your disease is responding to chemoimmunotherapy, you're inherently biologically very different from somebody who has chemorefractory disease. So anticipating this second scenario, this is an analysis we did now a couple of years ago now, where we looked again in the observational database of CIBMTR and selected out patients who at salvage attempt were only able to achieve a partial remission, and most of these patients were in partial remission. More than 95% of these partial remissions were confirmed on a PET scan, right? So we are not talking about patients who might have been PET negative and the CT may be falsely showing us disease. So these are really, really patients who went into transplant with partial remission. And again, this is the bottom line from these analyses, that chemosensitivity uniquely identifies patients where high-dose therapy and autologous stem cell transplant may still have a role to play. So in this analysis, in partial responders, again, if anything, patients who underwent an autologous stem cell transplant, there was a benefit both in terms of progression-free survival as well as overall survival. And the overall survival trend was even more remarkable because we were able to salvage autologous transplant failures with cell therapies down the road. It's often impossible to do transplant after CAR T-cell therapy failures. I've anecdotally heard that it works, but I've never done it myself. So when we published this analysis, there was a lot of blowback from many of my lymphoma colleagues that they would say, well, there are partial remissions and there are partial remissions. Some partial remissions are better than other partial remissions. In CIBMTR, we capture the nodal size of the largest lymph node. So I'm not going to bore you with more CIBMTR data. This is data from one of the institutions that really criticized that analysis. So this is an analysis done by investigators at MD Anderson, led by Dr. Saira Ahmed. And in this analysis, they looked at partial remission patients based on their metabolic tumor volumes. I don't have access to metabolic tumor volume data in the registry, but in Anderson they did. And I'm going to draw your attention to the curve on the bottom right. This is the probability of relapse in patients with high metabolic tumor volumes in partial remission, getting CAR T-cell therapy or autologous transplant. High bulk disease is a biologically poor disease. I see no evidence that CAR outperforms autologous stem cell transplant in these patients as well, right? So I understand the limitation in our analysis, but again, I'm not aware of any particular tumor volume cutoff where in chemosensitive patients, one modality starts to outperform the other modality. The third unique thing about the case that I showed you was the patient had MYC gene rearrangement, right? And we often say that even if you're chemosensitive, in MYC rearranged disease, high-dose therapy and autologous stem cell transplant may be not the way to go. And I would partly blame myself, right? So this is a very nice analysis done by Philippe Armand and Alex Herrera. Back then he was in Dana-Farber. I was one of the reviewers on this analysis, and clearly I'm not reviewer too, I'm a good reviewer. So this study got published. It basically showed that despite chemosensitivity, if you are a double hit large B-cell lymphoma, you do not benefit from an autologous stem cell transplant. So one of my fellows a year ago reminded me, why don't we do it? I said, because of this study. And she pointed out, she said, like, do you know there were only 12 double-hit lymphoma patients in this JCO paper, and all of those patients were, nearly everybody was in partial remission. So she insisted. He said, let me do an analysis where I can compare CAR with autologous stem cell transplant in MYC rearranged patients, and we had data available. I said, sure, go for it. So this was the analysis done by my fellow, Fatia Furkan. She's a junior faculty in MD Anderson, now very unfriendly institution for autologous stem cell transplant, unfortunately. But this is what her data shows. So we have 100 patients with MYC rearranged disease in the auto group, more patients in the CAR T-cell therapy group. Most of these patients were double-hit lymphomas, although a quarter were only MYC rearranged disease. And again, if you show chemosensitivity, we again see that in a subset of patients, the old-fashioned, cost-effective treatment of high-dose therapy and autologous stem cell transplant may still be relevant. So this publication just got accepted, will be hopefully coming out in press very soon. And again, is this just my bias? Is this just what I think? So We recently published ASTCT guidelines for transplant and cell therapy in patients with aggressive lymphoma. We asked this particular question. This guideline was led by another one of my fantastic fellows, Dr. Perla, who's a faculty in University of Utah now, and my very good friend, Dr. Eben Chen, was also on this guideline panel. And among our guideline panel, only one person disagreed with this approach. I hope this was not Dr. Eben Chen, but I think in the right scenario, remember as physicians, our job is, like CAR T-cell therapy is an incredible treatment, right? But our job is to pick the tool that best suits the patient that is sitting across you in your clinic room. So clearly in second-line therapy, CAR T-cell therapy is a practice-changing approach. It is applicable to vast majority of the patients we see. But part of the reason the second-line cell therapy trials were positive because second-line salvage therapies were really bad. RICE gets you an overall response rate of less than 50% in second-line setting. Do we have better salvage regimens now, right? So this is the data where the bispecific epcoritamab was combined with HiDAC-like approaches, and you can see, regardless of whether you're responding, failing treatment early or late, the response rates with bispecific incorporation in the second-line setting is a completely different ballgame round, right? The response rates are north of 70-75%. And in this analysis, among patients who responded to a bispecific-based salvage regimen, the very top curve is the small number of patients who underwent an autologous stem cell transplant. None of those patients relapsed, right? Again, identifying that chemosensitivity biologically identifies a very unique subset of groups. But that doesn't mean you should do autologous transplant for everybody who walks through your door, right? This is where our field is growing. So red arrow identifies the number of autologous transplants that are being done in the USA. The numbers are clearly declining and very appropriately so, and the numbers of cell therapies are clearly increasing. So this is at least how I approach transplant and cell therapy in aggressive lymphoma patients. Somebody with primary refractory disease, somebody too old, too frail to be a candidate for high-dose therapy and autologous stem cell transplant, of course, you go for CAR T-cell therapy. And by the way, these are the 80% of the patients in your practice are going to be cell therapy candidates. But in a rare scenario, if somebody walks through the door, having already shown that their disease is chemosensitive and they're young enough and fit enough, I still consider autologous stem cell transplant in those small subset of patients, but again, this is the minority of our patients. Second scenario is primary CNS lymphoma. We know primary CNS lymphoma is an uncommon disease, is biologically enriched for patients with non-GCB-like subtype. These patients historically had poor outcomes with chemotherapy-based approaches. But in the modern era, our practice has been to give them high-dose methotrexate-based induction regimens with rituximab typically, with temozolomide in our institution, but there are other platforms that incorporate thiotepa-like therapies. You induce the patients, and then we debate about how to consolidate those patients. There is a group that says we should do high-dose therapy and autologous stem cell transplant in these patients, and there is a group that shows that maybe whole brain radiation may be as good. So these are the long-term data from the Precious trial that compared autologous stem cell transplant with thiotepa-based conditioning versus whole brain radiation. So when they published their results early on, there was no statistically significant difference between autologous stem cell transplant and whole brain radiation therapy, but this is their 10-year follow-up. At 10 years of follow-up, there is no debate which therapy is winning, right? The red curve is the autologous stem cell transplant curve. And what is even more important is the rate of neurological function decline, right? So patients who get radiation therapy, their balance, their cognition is worse off in the long run, right? And it matters, right? You may cure your patients, but if they have advanced neurocognitive dysfunction down the road, it is biologically very important to keep in mind. The second debate is how to condition these patients, right? We often make the mistake of conditioning these patients with beam-like regimens. So this is an analysis that Craig Sauter and Mike Scordo at Memorial led using CIBMTR data. And it clearly shows that incorporating thiotepa-based conditioning is very important in these patients, right? Much of the preliminary evidence for thiotepa-based conditioning came from Dr. Eben Chen, at least in the secondary CNS lymphoma setting, and then in the primary CNS lymphoma setting. And in the registry setting, you clearly show that thiotepa-based conditioning is very important. Whether you're doing BCNU thiotepa or BUSI thiotepa, it is clearly superior to beam-based conditioning. So in my talk, this is the only indication you're going to see today where the numbers of transplants are actually increasing. So we published our CIBMTR data in 2021. Maybe it's coincidence, maybe it affected practice, but since then, the number of autologous stem cell transplant for consolidation of primary CNS lymphoma patients has actually gone up. And BCNU thiotepa is actually a very gentle regimen, right? I have done patients in their late 70s with BCNU thiotepa as an outpatient. They do perfectly okay. So in your community setting, if you see primary CNS lymphoma patients who are responding to induction, please send them for a transplant consolidation consult, even if the patient is relatively old and frail. Okay. The third histology we will tackle is an indolent lymphoma. So we are shifting gears from very aggressive disease to indolent disease. Again, a patient in my clinic, 57-year-old female, follicular lymphoma, gets BR in frontline therapy, and 23 months out, and I am intentionally using a 23-month cutout, the patient relapses, it's biopsy proven. Most of these early relapses are transformed disease. She does not have transformation. So I really like R-square regimen, so I put the patient on lenalidomide and Rituxan in second line, and within 2 months, the patient is in a complete remission. So what should we do for this patient? It's a POD24 patient. Should we do CAR T-cell therapy? Should we do autologous transplant on this patient? Should we just let it go, watch the patient? Or should we do bispecific antibody? Now, why is this 24-month cutoff important? It's important because of the work that Jonathan Friedberg and Carla Casulo did, and it clearly shows that when follicular lymphoma patients relapse early, their prognosis is really poor. By the way, this is common sense, right? Like diffuse large B-cell lymphoma relapses early, bad news. Breast cancer relapses early, bad news. Colon cancer relapses early, bad news. There's no rocket science in it, right? So many years ago, Carla Casulo and Jonathan Friedberg, when they were publishing these data, there was a second theme in the field was that when follicular lymphoma patients relapse, you don't see progression-free survival inversions in these patients. The first remission is longer than second, and second is longer than third, and the remissions keep shorter and shorter. So based on those historical data, Carla Casulo and Jonathan Friedberg asked us, can you tell who's POD24 in CIBMTR database? And we said, yes. He said, can we compare our study patients who never got autologous stem cell transplant with POD24 patients in the CIBMTR database? And we did that analysis. There are many limitations in this analysis. We did all the statistical matching we can do to account for population differences. And you see a signal in favor of autologous stem cell transplant. But I would point out, this is nearly a 7-year-old study, right? The field has moved on. So follicular lymphoma relapse refractory setting is a completely different beast now. We have R-square that we didn't have back then. We were starting to play with R-square at that point. We have oral EZH2 inhibitors. We have antibody drug conjugates. We have bispecifics. We have CAR T-cell therapy. And with all these nice drugs, is high-dose therapy still a relevant thing for these patients? So let's look at POD24 patients in the R-square trial. The R-square trial was not limited to patients with POD24 early relapsing disease, but if you focus on the POD24 patients that I've highlighted in the red text here, you can see that with R-square, even if you have POD24, your progression-free survival is about 30 months, right? You're doing better than what you did with your frontline therapies. So if you're responding to R-square, where is the data to consolidate these patients with a stem cell transplant, because if R square fails, how would you salvage this patient? Well, back then we didn't have cell therapy, now we have cell therapy, right? So I'm not going to show you all the cell therapy data. You know that I just had the Zuma 5 slides available most conveniently. I'm not part of this study, but I had those slides, so I'm going to show you these slides. So let's focus on just the POD24 patients. Again, POD24 patients with CAR T-cell therapy do less well than patients who do not have POD24, but they actually have reasonable durability of their disease control with CD19-directed CAR T-cell therapies with median progression-free survival of about 40 months. Very reasonable. Now, when Zuma 5 was going on, we didn't have bispecifics. Now we have 2 FDA-approved bispecifics in the clinic. We have mosunetuzumab and epcoritamab with very high overall response rates, north of 80%, CR rates north of 50% in these patients in third-line settings. And I think we are scared to say that bispecifics may eradicate disease in patients with follicular lymphomas, but it is entirely possible in a subset of these patients. Now, on your left side of the screen are the progression-free survival curves for mosunetuzumab, which is a fixed duration therapy. It's not a therapy that goes on forever. And you can see that these patients who responded, their duration of complete remission. So these are the best of the best responders, but the responses are durable, and many of those patients are in ongoing complete remissions, completely off of therapy as well, right? So when we did the CIBMTR study 8 years ago, we didn't have R square, we didn't have CAR T-cell therapy, we didn't have bispecifics, we didn't have tezometostat, we didn't have tafasitamab, we didn't have loncastuximab, right? So how do we approach follicular lymphoma in relapse setting now? When a patient relapses, I do ask, is this a heavily pretreated disease? Does the patient have POD24? And if the answer is no, we have many targeted immunotherapies available to treat these patients. In patients who do have these risk factors, you have 3 options. You have autologous transplant, CAR T-cell therapy, or bispecifics. Over the years, I'm doing few and few auto transplants in these patients, but it is maybe relevant in areas with lack of access to cell therapy, lack of access to bispecifics. CAR T versus bispecifics is a debate. You have to talk to your patients about it. Some patients have a preference to get a treatment once and then be done at least for a while. Then I gravitate toward CAR T-cell therapy. But I had to admit that most of my patients, I generally do CAR T-cell therapy after bispecifics fail, but that's an individualized decision based on what the patient wants. Some patients don't want to come every 3 weeks getting mosunetuzumab, and for those patients, we gravitate towards CAR T-cell therapy. And this is where our field is going, right? So number of autologous stem cell transplant, this is the deep blue curve, very appropriately dropping in the US. I think we do more CAR T-cell therapies than we should in follicular lymphomas. So there was a bubble of excitement for cell therapies in follicular lymphomas, but it's generally leveling off now. Now, what about mantle cell lymphoma? I think this is going to be the histology where your practice will change if it has not already changed, right? So let's look at this 47-year-old patient. She presented with symptomatic mantle cell lymphoma in my clinic. She doesn't have TP53 mutation, but her MEP score is high risk, right? Her Ki67 was high risk. This is biologically not a full mantle cell lymphoma you would do watchful waiting on. Symptomatic patients in our group, many years ago, our consensus was to do the Nordic-like approach, which is a CHOP-like therapy alternating with high-dose cytarabine. This is the regimen we use. The patient responded well. She achieved a PET negative remission, and one of my previous colleagues, Dr. Fensky, eventually convinced me to do clonoSEQ MRD on every single patient, and the patient was clonoSEQ negative as well. So what should you do for this patient? This is a chemosensitive patient. I just said, autologous stem cell transplant is the best thing since sliced bread for chemosensitive disease, right? So now maybe I'm going to contradict myself. Should you do transplant on this patient? Should you do just Rituxan maintenance? Should you do BTK inhibitor maintenance? Or should you take this patient to CAR T-cell therapy? I don't know why you would do that, but that's an option. So do we have randomized data for autologous transplant in mantle cell lymphoma? Yes, this is the European study done nearly 20 years ago by the European Mantle Cell Lymphoma Network. They randomized mantle cell lymphoma patients that were predominantly treated with CHOP, but there were some R-CHOP patients on this study as well. And the study showed that transplant consolidation had a progression-free survival benefit, which is the standard for every single FDA approval in every single myeloma drug, but there was no survival benefit. Now, the problem with data like these are, you can interpret it whichever way you want. Lymphoma doctor said there is no survival benefit, you shouldn't do auto transplant. People like me said there is a progression-free survival benefit, I'm absolutely going to do transplant on it. We had retrospective data that show both outcomes. I'm not going to talk about the triangle study. This is a European study, and in Europe you treat your patients very uniformly, which doesn't happen at least in my clinic. When I see mantle cell lymphoma consults, somebody gets Nordic, somebody gets the triangle approach, somebody gets BR, somebody gets BR with acalabrutinib. Plus, I'm a simple guy. Whenever I look at triangle data, I get more confused. I just can't understand what they did in that trial. So what I'm going to stick to is the ECOG study that my colleague Dr. Fensky, who's enjoying his life in San Antonio now, led. It's a very simple study, the way we treat patients in USA. You give whatever induction you want to give to your patients, but at the end of your induction, if your patient is PET negative and MRD negative with clonoSEQ, these patients were randomized to transplant or Rituxan maintenance. This is basically the schema of this trial. By the way, if your MRD analysis failed, or if you were MRD positive, all of those patients got high-dose therapy and autologous stem cell transplant. Now, I will be the first to admit, I thought this was a foolish trial. I did not enroll patients on this trial enthusiastically, right? Because I thought the trial will show that these are chemosensitive patients, transplant will win. These are the characteristics of these patients. This is a Herculean effort of 500 plus patients randomized to transplant versus no transplant. And at the second interim analysis, the investigators were asked to stop enrollment on the trial because you can't thread even a needle between the transplant arm and the non-transplant arm, right? So on the top is the PFS curve, at the bottom is the overall survival curve. Maybe I have inverted them, who cares? There is no difference, right? Between transplant and no transplant, the futility boundary was passed, which means you can enroll more patients, the trial is not going to show a difference, right? So I think this is a practice-changing trial. That's why it was a late-breaking abstract at ASH. The rumor is it will get published in a very good journal. And this is what is happening to our field. We didn't talk about cell therapy because it's not relevant, at least right now, in frontline therapy, but cell therapy numbers in relapse setting are going up, and autologous stem cell transplant numbers, I suspect, will keep going down. And we started 10 minutes late, so I think I have 5 minutes, right? Okay, so this is our last part, nodal T-cell lymphomas. And this is super brief. This is just a plug for a trial that is also open in your centers. So we know T-cell lymphomas, at least in the nodal subtype, are aggressive diseases. We treat them kind of like B-cell lymphoma with CHOP-like approaches. But generally, with the exception of ALK positive anaplastic large cell lymphomas, where BV-CHIP has been a game changer, most of these patients do not have their outcomes as good as their B-cell counterparts. So in this setting, if a T-cell lymphoma patient achieves a complete remission, we often consider high-dose therapy and autologous stem cell transplant. The problem is we have randomized data for transplant in aggressive lymphoma. We have randomized data, by the way, for follicular lymphoma, the CUP trial. We have randomized data for mantle cell now. We have randomized data for Hodgkin that I don't have time to talk about today, but no randomized data for T-cell lymphomas. And when you don't have randomized data, you look at whichever study that aligns with your bias, right? So I'm going to show you both studies. This is the data from a European group, the gel-THAMO analysis that does high-dose therapy autologous stem cell transplant consolidation in some patients, not in others. The bottom line is the study shows that there is a PFS benefit in favor of transplant. So if you're in the transplant group, you would say, aha, we should do transplant in these patients. Maybe you're like me because I'm not a huge fan of autologous transplant and T-cell lymphoma, so I go to this French study and say, hey, did you see that analysis in Annals of Oncology? There is no benefit of transplant. But thankfully now, ECOG has just activated and released a very important clinical trial in T-cell lymphoma patients. This is an incredibly hard study to enroll on because these patients are uncommon. So T-cell lymphoma patients in CR will be randomized to transplant or no transplant. Your very own Dr. Mark Hoffman is a co-chair on this study. So please support this analysis. I think this is an incredibly important but hard to enroll study. And hopefully it will give us an answer whether we should do it or we shouldn't do it. But this is what the field is doing. Since we don't know what we should do, the trends haven't really changed, right? Most of the curves I've shown, one curve was going up, everything was coming down. This is stable. Why? Because there is equipoise. I don't know whether transplant helps or not, and I think it is ethical to randomize these patients. So I'll wrap up. My take-home messages is large cell lymphoma patients, CAR T-cell therapy is absolutely the dominant player. But maybe for a very small subset of patients, autologous stem cell transplant may play a role. Primary CNS lymphoma, I think we have very good data that in patients who can tolerate high-dose therapy, it is the way to go because your long-term cognitive preservation is much better. Follicular lymphoma, I think we have so many agents where I don't think every patient walking through the door needs transplant or cell therapy, but it is important in third or later lines of setting. Mantle cell lymphoma patient, upfront setting, I think transplant, at least in MRD negative patients, should be questioned. But we didn't talk about the TP53 mutated patients, where in CTN, we are designing a study that will apply CAR T-cell therapy for very high-risk mantle cell lymphoma patients in the upfront setting. And in the T-cell lymphoma setting, please work with Dr. Hoffman in Kansas and support that ongoing analysis. So I'm really grateful for your attention. I have a very quick flight after my talk. I would have loved to stay in Kansas longer than I had to. So thank you, Joel, for your invite. I'm really, really grateful. So.
Outstanding talk, Dr. Hamadani, and the downside for you is that I'm going to invite you again in the next couple of years to give us yet another
Next time I'm going to try Joe's then. I haven't tried that. So.
And I'm going to ask you a completely unfair question that you can't possibly answer in 2 sentences, but please do so in just a couple sentences. And so all of the above fail. Allogeneic transplant have an important role?
Absolutely, right? So your question is specifically for large cell lymphoma?
All of the histologies you covered.
Oh, so let's start with the histology where it is extremely important, right? So T-cell lymphoma patients, we have a 2,000 patient study in collaboration with EBMT. T-cell lymphomas are uniquely sensitive to GVL effects. Don't do it up front, although there are some histologies where you would do it, hepatosplenic T-cell lymphomas and such aggressive histologies. But nodal T-cell lymphoma patients who relapse and they happen to have a remission, allogeneic stem cell transplant is curative. It cures about 60% of the patients, and now it is the #1 allo transplant indication for T-cell lymphomas. In patients with aggressive lymphoma, we still do allo transplants, but these are generally patients who fail cell therapy but then they are lucky enough to get a complete remission with something down the road, maybe bispecifics. So among those select few patients, one of my fellows, Joanna Zerko and Alex Herrera, had a very nice paper in Hematologica that shows that yes, you can do allotransplants in CAR failures and salvage a subset of those patients. Follicular, I spent a good chunk of my life arguing that you should do allotransplants in follicular lymphoma patients, but I don't think that is the way to go anymore. And mantle cell, absolutely, after CAR T cell failure, it is still a very, very useful modality. Eben.
Okay, there you go. Great talk. I have two questions. One, you showed data with very small numbers. I'm not blaming you. It's probably the only data that exists. But in terms of large cell lymphoma patients who had responded to bispecifics and then went to auto transplant, right? I mean, so I think we can all buy if salvage conventional chemotherapy works or they're chemosensitive, then consolidation with high-dose therapy makes a lot of sense. I think it's difficult to buy if you responded to a bispecific, meaning immunotherapy without a conjugate or anything like that, then auto transplant makes a lot of sense because they're just different mechanisms. So can you comment on what the future of that data set will hold if you think it'll really hold true? And the second part of that question, the second part of the question is if patients relapse after CAR T, all right, which we do see a fair share of those, right? Because CAR T is not the home run that some make it out to be, and then are able to get back into a CR with, say, a bispecific or something. Is there any role for auto then, or is it all just an allo playground?
So I'll answer the second question first, right? Like most of my CAR failure patients, by the time they relapse and respond to something, they generally don't have the hematopoietic reserve to collect stem cells. But in the CABMTR database, right, there are like 20 cases of auto transplants after CAR failure. So you can already imagine how uncommon that scenario is. Your first question, is chemo plus bispecific relevant? And I would say yes, it is relevant at least for late relapsing fit patients, right? Those patients, now we have a good salvage platform available that if you happen to do transplant in these patients, give them chemo plus salvage, although the label is likely going to be transplant not intended patients, but we can use that, right? The other argument is, if somebody gets to chemosensitive disease with predominantly bispecific, is high-dose therapy relevant? And the answer is we don't have any data that it is not, right? So we know Hodgkin patients who get into CR with just a checkpoint inhibitor, they do beautifully well with high-dose therapy. Hodgkin patients who just get into a CR even before checkpoint inhibitors with brentuximab vedotin-based regimens, they do fine with high-dose therapy, right? So there is no reason to believe that if your CR is bispecific based, high-dose therapy may not be relevant, because it is entirely possible that the cellular immunotherapy by bispecific is eradicating a different clone of the disease, and chemo will eradicate a different clone of the disease. So I think we are way over time. Thank you so much for your attention, and your barbecue is the best. So.